Thanks very much, Francois, for that interesting introduction. Can I have I haven't got a clicker. First slide. Oh, okay, there we go. Is there somewhere to move it? Maybe the Prime Minister's gone off with a pointer. I don't know. It's a pointer. I don't know. It's gone.
I haven't done a very good job.
You're going to get fired. Okay, no conflict of interest. So if you go to the WHO in Geneva, there is a very poignant statue of a young man leading a blind person, his grandfather. And this is I think, a very important depiction of neglected tropical diseases in Africa. This depicts onchocerciasis, a parasitic disease, the second most important infectious cause of blindness in the continent, and 99% of these cases occur in sub-Saharan Africa. Over the last 40 years, we've seen considerable success through mass drug administration of ivermectin as a donation program, a vector control program clearing the bush of the black flies, and this has resulted in 600,000 cases of blindness avoided, 1 billion cases, 1 billion treatments administered, and 25 million hectares of fertile land secured as part of this program. So they may be called neglected tropical diseases, but there's a lot of work in moving the pathway forward. I think that first slide captures a lot of what is said here. And like HIV, these are diseases that perpetuate poverty, they're discriminated against, they cause despair and economic loss. Many are associated with disfigurement, just think of leprosy, disability, and some lead to a lingering death or a much quicker death if you look at rabies. So these are some of the classical diseases that fall under the Neglected Tropical Diseases program. I think many of you will recognize them in your parts of Africa. Recently, they've introduced NOMA, which is a very disfiguring condition of unknown etiology, particularly seen in Nigeria, and surprisingly, snake bites, which cause a large number of deaths in the continent. So this is the focus of the Neglected Tropical Disease Program. I think this slide is really telling. As mentioned this morning by Victoria, who said that we need science to guide our interventions. Well, if you look at neglected tropical diseases, compare what the publications are for disease like HIV, you can see for selected neglected tropical diseases, there are very, very few. And I would encourage scientists in this audience to reach out, become part of the NTD family, and we need new interventions, we need new discoveries, and as you move towards the last miles, towards elimination, you need even more drugs, a change in diagnostics, and definitely new approaches. So for the NTDs, 2007 was the turning point. There was a WHO meeting of partner to work together in an innovative and cooperative way to look for flexible, cost-effective ways of either controlling the diseases, moving towards elimination as a public health problem, or eliminating in a specific area, or in the cases of some, eradication. And I would advise you, if you want to see what's happening, and there is lots happening, to go and consult the website. So the interventions are really around specific ones. Some of them may be similar in the HIV field. NTDs rely a lot on mass drug administration as chemo prevention. There's large-scale distribution of drugs and community-led, community-placed programs. And I think that is absolutely key to their success. Of course, there needs to be individual case management. We do need specific drugs. We need new drugs. We need good diagnostics for cases, and we need diagnostics for surveillance, particularly as we move towards elimination. Together with this, a number of them are associated with vector transmission, so vector control is particularly important. There's been mention, and very little mention so far, of One Health. Many of them are zoonotic diseases, so working together with the veterinarians in public health is absolutely critical. And then applying the basics, which many people don't have access to in many parts of the world: clean water, good hygiene, and wash programs. We need integrated, effective public health programs. That's the sentence you see bandied around everywhere. I think we often don't pay enough service to it. And I think what the NTD program does particularly well is their private-public partnerships. And every disease has their special partner who are very involved, not only with donations, but also taking care of many of the aspects of the control, treatment, and prevention. This is the disease that some of you may recognize. This is guinea worm or dracunculiasis. There were 3.5 million cases of this disease towards the end of the last century. Today, with very good control, we are down to just 17 cases. There may be some others in areas that are not surveyed well, but that's in Chad and South Sudan, and efforts are being put in there. It's quite a difficult areas to work in. But now what we're seeing are change in hosts and reservoirs, and now dogs are becoming very much part of the cycle, so that One Health approach is very important. So dracunculiasis or guinea worm is transmitted to people who don't have access to clean water. They use water from contaminated areas where there are fleas that contain these guinea worm, and when they bathe in that water, they ingest it, or it's applied to the skin. The larvae infiltrate, make these terrible lesions. They are very painful. They then go and bathe in the same water, and so the cycle continues. So the dracunculiasis eradication program, as I've mentioned, has moved really in great leaps and bounds. There you see some of the innovative tools. There's no treatment. It's local care of these dreadful wounds and preventing or reducing access to contaminated water. Simple interventions. There are these filters. If you want to drink from that contaminated water, you use this filter, and it removes or prevents those fleas with the worms being ingested. There are filters that the lady on the right is using, very simple interventions. And I really want to pay tribute to the Carter Center. Ex-President Carter's dream was to see the eradication, and he almost did. The other eye-related infection is trachoma, really a dreadful affliction. Being blind in Africa reduces all possibilities of just simple day living and employment. And you can see the SAFE strategy that has been applied. Again, mass drug administration, surgery, and clean hygiene, access to clean water and good hygiene. So rabies, which is very close to my heart, is always fatal. Any infected animal or child, usually a child or patient, will die. It is preventable by either pre or post prophylaxis, usually with vaccines. It's one of the few neglected tropical diseases where a vaccine is effective, and the most effective, strategic, cost-effective intervention is vaccinating dogs. An ambitious target, 2030, to eliminate dog-related, dog-acquired rabies in humans. Are we there yet? Not sure. And new drugs for old diseases, incredibly important. Victor Kamisi is one of my heroes. I've never met him. He's done extraordinary work in the D.Sc. He's pioneered the treatment. He's been part of the drug development, and most recently, the development of fexinidazole oral, once a day, 10-day treatment for a disease that previously required admission to hospital for toxic intravenous drugs, clearly not an option in Africa. And because of this treatment, because of these incredible trials, and there is a publication this week in a prestigious journal highlighting what can be done when you apply yourself to a problem. I think we're almost done. Lymphatic filariasis, elephantiasis, disabling hydrocele, again, a filaria transmitted disease. Mass drug administration has really made a huge difference to this problem. So when you bring HIV and neglected tropical diseases together, when they collide, we all have program challenges. We're all still feeling the effects of the COVID pandemic. Absolutely lots of concerns around funding gaps. Migration, natural disasters, civil unrest have a major impact on these programs. But there are some program positives. It's community leadership, lots of experience with supply chains, MDA, and partnerships that I think HIV can learn from NTDs. And then I'm going to hand over to my co-presenter, Flavia Magali, to talk about some of the interactions between the diseases. In HIV, you may see more severe disease from NTDs. There's a reactivation risk. There is a predisposition to HIV, particularly in female genital schisto, and of course, the overarching concerns about stigmatization. So Flavia, over to you.